So Manoria sir is a legendary teacher, master teacher, and occupied apex positions in API, CSN. All we have been always learning from him. It's always pleasure and learning experience through it. I cannot introduce any further. He's a DM Carr, director of Manoria Heart Care Center. And this is a kind of the topic, familial hypercholesterolemia. But believe me, he's going to tell us some pearls which are going to be very interesting and we can learn, because FH existence in India is not as rare as we think of. It's a malady that I encounter at times, even in a day in, day out clinical practice. As Smith was saying in the maiden talk, that we Southeast Asian ethnicity are at the highest risk of events, and we are actually different metabolically. But where in this metabolism, the role of FH has been lost somewhere, and FH does exist, and how to approach differently. So I hand over to Manoria sir, and then listen to him, then we'll usher in a discussion in aftermath. Manoria sir, please.
Are you able to hear? Are you able to hear?
We can hear.
Yes, sir. Perfect.
We can hear you, sir. We request you to share your presentation, sir. At the bottom side, yeah, perfect. 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 I request you to go for full screen. Perfect, sir. Visible.
Good evening, everybody. The last couple of years has witnessed spectacular advances in the field of familial hypercholesterolemia, both in terms of enhanced understanding and in the availability of a panoply of therapy options, as you can see on the screen. There is no doubt we are now able to understand lipid metabolism much better. We know the genesis of familial hypercholesterolemia, we know the clinical features, the extent of the disease, and the ravages. But despite familial hypercholesterolemia being a life-threatening disease, it is underdiagnosed, undertreated, and it is a time to get familiar with familial hypercholesterolemia. This shows the worldwide prevalence in the general population. Indians come under the category of unknown, and we need to change this. Familial hypercholesterolemia, as we know, is a common genetic cause of premature coronary heart disease and calcific aortic valve disease. One baby is born with HeFH every minute, and liver plays the key role in HeFH. There is markedly reduced hepatic capacity to clear LDL from the blood, resulting in its accumulation. Now, HeFH is typically caused by mutations in LDLR, ApoB, PCSK9, or LDLR1, or other as yet unidentified genes. Most common genetic defect is in the LDL receptors. If there is mutation in any of these, this results in diminished clearance of LDL from the blood. Now, normally, the LDL particle binds to the LDL receptors. It is taken inside the liver cells and is cleared. And the LDL receptor is recycled. Now, if there's a defect mutation in any of these, suppose there's a mutation in ApoB, there will be problem in the binding of the LDL particle to the LDL receptor. If there's a problem in the LDL receptor, there will be problem in endocytosis. If there's gain of function of mutation in PCSK9, the PCSK9 also binds to the LDL receptor. The LDL is cleared, but the LDL receptor undergoes lysosomal degradation and cannot be recycled. And there's a defect in the LDLR1. There will be problems in internalization and recycling via the clathrin-coated pits. Now let's look at the genetics and the pathophysiology. Familial hypercholesterolemia is most often caused by mutation in LDLR gene, resulting in absent or dysfunctional receptors on the surface of hepatocytes. More than 1,700 mutations in LDLR gene on chromosome 19 have been identified. Defects in genes encoding ApoB, PCSK9 affects account only for a minority of cases, and the LDL receptor adapter protein, that is LDL-RAB1, is a very rare recessive form of familial hypercholesterolemia. Now this shows the genetics of FH. As you can see, LDL receptor, 60 to 80% patients of FH are attributed to it, more than 1600 causal mutations, chromosome is 19, ApoB 1 to 10% only, chromosome 2 and handful. PCSK9 again only less than 5%, the chromosome 1 is involved in this handful, and there could be unknown 20 to 40%. What is very important to realize is that the yield for genetics testing in definite FH may be to the tune of 80% versus probable and possible where is only 35 to 60%. Now, inheritance of a mutation in the gene from one parent causes heterozygous FH, from both the parents, homozygous. What is very important to remember is besides the LDL, you must look at all other components of the lipid profile, because if the LPA is elevated, it increases the atherogenic risk. Elevation of LPA greater than 50 increase the risk of ASCVD in FH from 3.2-fold to 5.3-fold and should always be targeted to minimize ASCVD in FH. Elevated triglyceride lipoprotein nephrin, dysfunctional HDL, which collectively contribute to accelerated ASCVD and CHD. Indeed, every 10 milligram per deciliter increment in non-HDL is associated with an increase in atherosclerotic burden equivalent to 1 year of aging. There could be markers of inflammation and endothelial dysfunction also. Whenever we are treating these patients, attention must be focused on all other risk factors as we do in our clinical practice. Now, this is a very, very interesting slide and shows the effect of load of LDL on ASCVD. Now, imagine if you are a normal individual without FH, the threshold for CHD is reached by 55 years. Now, if you have homozygous FH, the threshold for FH, you can see on the left side of the slide, is reached only by 12.5 years. And if you have a heterozygous FH, the threshold is reached by 35 years. What is very interesting is if you start even a low dose statin at the age of 10 years in HeFH, the threshold for CHD is reached at 53 years. But if you start a high dose statin at the age of 20 years, the threshold for CHD will be reached early at 48 years. So what is very important is initiate statin early after making an early diagnosis, reach the goal early and stay at target. The earlier you start, the better is the result. The higher dose you start in the early period, the better are the results. What about prevalence? FH is more common than we believe it. Founder effect, although FH affects all races, ethnicities, certain subpopulation experience FH at a higher frequency due to presence of a founder effect. This particular phenomena is characterized by loss of genetic variability that arises when migration of few individuals carrying a high frequency of FH causing genetic mutation establish a new population and live in the relative geographic and cultural isolation. In addition to French Canadians, FH founder population that have been previously identified and characterized include Ashkenazi Jews, Christians, Lebanese, Finns, and South African. Now, this is a meta-analysis of 11 million subjects, and you can see ischemic heart disease is 10-fold higher. Premature ischemic heart disease is 20-fold higher, and severe hypercholesterolemia is 23-fold higher. All of us are versed with the clinical presentations, and there are differences in penetration if you are having a heterozygous FH or a homozygous. Heterozygous FH occurs 1 in 500, whereas homozygous is less common, 1 in 1 million. Heterozygous is 1 mutated allele, and the other one is 2 mutated allele. The total cholesterol may be to the tune of 350 to 500 in heterozygous FH, whereas it is much higher, 500 to 1000 in homozygous. LDL cholesterol may be 200 to 400 in heterozygous FH, where it is more than 600 in the homozygous. Half the number of LDL are expressed, so a therapeutic response may be better, whereas LDL receptors may be, activity may be absent also, so there is problem in getting therapeutic response to statins and PCSK9 inhibitor. The FH heterozygous is characterized by 2 to 3-fold elevation in plasma LDL cholesterol and often develop myocardial infarction as early as 30 to 40 years. Whereas homozygous, homozygous FH, LDL levels are elevated 6 to 10-fold from birth, and heart attacks may occur even in childhood. All of us, I think, are very familiar with the clinical presentations. You can see xanthelasma, corneal ulcer, Achilles tendon xanthomas, tendon xanthomas, tubular xanthomas, and planar xanthomas. And these are very, very important features of familial hypercholesteremia. Clinical course, the hallmark of FH is severe vascular disease occurs at an early age. If you have an atherosclerotic vascular disease at an early age, don't forget FH. Numerous case report of CABG or death before the age of 10 years, and the aortic valve is also commonly involved, produces severe calcific aortic stenosis. Untreated, usually death occurs at 30. LDL apheresis may be required, and even with maximum and optimum therapy, disease continue to progress. And this is the usual story of a homozygous FH. CABG is done at the age of 23 years, re-CABG done at 36 years, PCI again 40 years, severe aortic stenosis, calcific, died at age 45 years while awaiting TAVI. And CT angiography is an excellent modality to have an overview of the vascular system involved in the FH. You can see extensive calcification of the aorta, you can see extensive calcification of the aortic valve, and also calcification in the descending aorta and the common iliacs. What about heterozygous FH? In heterozygous FH, 20-fold increased risk of ASCVD. If untreated, men have 50% risk of ASCVD by age 50, women 30% risk of ASCVD by 60, and many heterozygous FH will have established CVD. What about screening these patients? You can have a clinical screening and a genetic screening. Genetic screening is not available everywhere. So clinically, you can have a lipid profile and a family history. And there are 3 criteria recommended: Simon-Broome criteria, the Dutch Lipid Clinical Network, and the criteria, the European Atherosclerosis Society criteria. The genetic tests, as we said, if are available, is good, but at many places they are not available. Now, the Simon-Broome criteria for FH is a simple one. It has only 5 points: total cholesterol level more than 290, LDL more than 190 in adults, total cholesterol more than 260, or LDL more than 155 in children younger than 16. And as I already showed you, tendon xanthomas in the patient, or tendon xanthomas in a first or a second degree relative, DNA-based evidence of LDL receptor mutation, familial defective ApoB 100 or a PCSK9 mutation, family history of MI before 50 in a second degree relative, or before age 60 in a first degree relative, and family history of elevated total cholesterol more than 290 in an adult first or second degree relative, and family history of elevated total cholesterol more than 260 in a child, brother or sister, 16 years. The diagnosis is definite if there is 1 + 2 or 3 on possible if there's 1 + 4 or 5. Now, this is the Dutch lipid network criteria. I think all of you are familiar with. It has multiple components, and definite or familial diagnosis of HeFH is made if the points is more than 8, probable 6 to 8, possible 3 to 5, and unlikely if there's conceived. And this is the EAS consensus criteria. You have to demonstrate a genetic confirmation on LDR, ApoB, PCSK9, or rarely LDLR1, or in untreated LDL cholesterol more than 500, or treated LDL cholesterol more than 300, together with either cutaneous or tendon xanthomas before the age of 10, or untreated LDL levels consistent with heterozygous FH. Genetic testing is not routinely done. However, genetic testing is the gold standard for diagnosis. Genetic testing can be used in cases where diagnosis is unclear. Testing generally involves sequencing 3 genes, LDR, ApoB, and PCSK9. The yield is 85% in definite and 50% in possible category. Genetic testing may become more accessible and may be particularly useful for cascade screening. Now, it has been recently shown in a large cohort that less than 2% of individuals with LDL cholesterol greater than 190 had FH mutation. Conversely, 27% of LDL receptor mutation carriers have LDL cholesterol less than 130. Now, there are some differences between the clinical and genetic testing. All of us know the clinical criteria can be applied everywhere. You can check the lipid, you can have the clinical examination and take a family history and do cascade screening, but genetic is not everywhere available. Now, what are the recommendations of LAI? The LAI expert consensus recommends universal screening of all individuals prior to the age of 20 years at the time of entry in the college, or earlier of heterozygous or homozygous FH. It also recommends the Simon-Broome criteria for diagnosis of FH because of ease of mutation and not the LDL measurement to identify the affected biological relative. If no, use specified gender and age-specific LDL criteria to identify affected biological. Now, this shows the evolution of therapies for FH. In 90s, the treatment was very unsatisfactory. We had diet, very poor drugs, apharesis, and liver transplantation. But between 90s and 2000, we have statins and apharesis. Between 2000 and 2010, Ezetimbe was added and apharesis was continued. And 2010 to 2017, we have the wonder drug, PCSK9 inhibitors. And 2020, besides the old drug, we have now bempedoic acid and 3 investigational drugs, NGPTL3 inhibitors, gemcitabine, and the gene therapy. What is very important to realize when you are treating these patients with statins or PCSK9 inhibitors, that the magnitude of achieved LDL reduction with statins or PCSK9 depends on the residual LDL receptor. Patients without residual function typically will not respond to PCSK9. Nonetheless, for majority of HoFH patients who do have residual LDL receptor activity, high-dose statins typically reduce LDL cholesterol by 10 to 25%, Ezetimbe by 10 to 15%, and PCSK9 by 20 to 30%. Now, what should be our strategies for management of FH? Lifestyle modification, very important. Statins are the first-line drug. Should be initiated if LDL is more than 160, and treatment with statins can be started at 8 years, and if it is HoFH, maybe earlier after discussing with the physician. Ezetimbe can be added. It produces an additional decrease by 15 to 20% in LDL cholesterol. Bempedoic acid is a new addition, approved by USFA for HeFH in Feb 2020. It decreases LDL cholesterol by 70 to 80%. And if you use it with Ezetimbe by 36%, PCSK9 inhibitors, we have evolocumab and evolocumab, Mipmoresen and Lomitapide are only for HoFH. We have LDL apheresis and liver transplantation. So whatever is statins, statins are the first agent to be used, and they improve the cumulative event-free survival. As you can see, the blue one is the statin and the dotted is no statin. So there's substantial improvement in the Kaplan markers when you statin. Bempedoic acid is a new addition. It inhibits the synthesis of cholesterol one step earlier than statins, and it inhibits the ATP citrate lysis. The beauty of this agent, it doesn't produce muscle symptoms. This is the Clear Harmony trial. You can see bempedoic is 180 milligram per day. This trial has also HeF patients besides ASCVD and other groups. And this is the Clear Wisdom trial, which also have HeF agent, and it produces about 15% reduction in the LDL cholesterol. And if you use both these agents, bempedoic acid, it can be reduced by 36.2%. What are the other drugs? The other strategies in the management of which could be you decrease the hepatic production of LDL either by MTTP inhibitor, that is Lomitapide. It can be used orally in 5 milligram, can build up the dose up to 60 milligram, but these are poorly tolerated. GI side effects, diarrhea, and fatty liver can occur. Or you can use Mipmoresen, which is antisense to ApoB, and it can be used in 200 milligram per week subcutaneously. It can produce injection site reaction, true light reaction, and hepatocytes, hepatic steatosis. And we have the PCSK9, which increase clearance of LDL from the liver. Now, this is the data on elaricumab in FH. Both Odyssey FH1 and FH2 were evaluated. Patients were evaluated with PCSK9 elaricumab, and you can see there is substantial improvement in the LDL cholesterol in both FH. And this is the famous TOSIC trial, which had 300 patients with homozygous and severe heterozygous, 4.1 year duration, and they're all subset of patients with apheresis, no apheresis, adolescents, and adults, and it also showed a substantial benefit. And this is the Odyssey Kids trial, the phase 2 trial, which tried to see what is the effect of elaricumab in these pediatric patients. It has 4 doses in different stents, and it also produced a substantial reduction in LDL cholesterol. And the conclusion was in pediatric HeFH patients, LDL reduction was greatest in the highest dose, and it was well tolerated. There are a panoply of new agents which are showing exciting results. Evolocumab, a monoclonal antibody targeting angiopoietin-like 3, has been shown to reduce LDL cholesterol by 49% in a study of 9 patients with HoFH against various background lipid therapies, and is remarkably well tolerated. Jamcabine, which reduces the synthesis of hepatic cholesterol, triglycerides, and ApoC. You saw the data of ApoC deficiency in the previous lecture. Several proof of concept phase 2 trials in non-FOH population have shown LDL cholesterol reduction of 30% when Jamcabine was added to statins. And the impaired LDL receptor in HoFH appears to be an ideal target for gene therapy. What are the indications of LDL apheresis? This is also a very important modality, not available in country, costly, and also a little cumbersome. If you have HoFH, that is homozygous, which is unresponsive to drug therapy with LDL more than 300, you can submit for an LDL apheresis. If it is a hydrolyzed HF, unresponsive to drug therapy with LDL more than 300 and 0 to 1 risk factor, or LDL 200 with greater than 2 risk factor. LPA, again, I'm pointing out, this is also associated with FH. If LPA is elevated, you must also target LPA to improve the prognosis of these patients. And this shows the data on LDL apheresis. You can reduce the LDL substantially by up to 76%. There may be rebound. And so what are the lipid association recommendations? LDL targets to be achieved children HoFH, that is homozygous, less than 70. Heterozygous, less than 100. Adults, HoFH, less than 50. HeFH, less than 70. And at least 50% reduction from the baseline LDL. What is the LI recommendations? For those who have ASCVD, if it is heterozygous, LDL should be less than 50 and less than 30 is an optional goal. If it is homozygous with ASCVD, very, very high risk patient, less than 30 should be the goal. So in conclusion, FH is a common and a potentially lethal genetic disorder, but unfortunately it is underdiagnosed, undertreated. The diagnosis can be made easily on clinical grounds. Cascade screening is essential. Therapeutic options, we have a panoply of them, and eliminate other ASCVD risk factors when you are treating. What are the futuristic approaches in unresolved issues in FH? Now, the currently available drugs only blunt the progression of disease. They does not cure it. We have new drugs, inclisiran, which is emerging as an exciting agent. A single injection of 300 milligram decreases LDL by 50%. This remains there for 6 months. Orient 2 in HoFH is ongoing. PCSK9, another emerging new therapeutic inhibition. A single vaccine decreases LDL by 50%, remains there for 1 year. And if this becomes a real reality, a booster dose every year. Time and again, sometimes we are faced with the question, can FH be cured? All these drugs only blunt the malignant progression of FH. A gene therapy for homozygous FH is in its infancy, but may offer a potential cure in the future. What about liver transplantation? Considerable morbidity and mortality is there, all of us know, but this can be considered when the mortality of FH exceeds the risk of dying from transplant. And whether liver transplantation could be performed in children without coronary heart disease, or one should wait for coronary heart disease to develop, is controversial. And the issue of heart liver transplantation in those who have developed coronary artery disease is another controversial consideration, but I'm sure with progress in science, we will be able to clarify all these newer modalities of treatment with great precision, and maybe they may be applicable in the clinical context. Thank you very much for your kind attention.